Good afternoon, ladies and gentlemen. I'd like to thank Colgate for inviting me to give this lecture, and I hope you're here because you're interested either in epidemiology, or you're interested in the older patient, or you're interested in prevention at all stages in the clinical field. These are the aims of my talk, which I'm sure you're particularly interested in, and you certainly want to get your CPD. But really there is sort of three parts to the talk. One of them is looking at the overview of the latest national data about the ageing population. The other is about a review of what epidemiological information we have about the oral health of the older population. And then we need to have a look as well about delivering evidence-based caries prevention for that older population. So just some numbers, which are probably, I don't know whether they're scary or they're good news, but these are the facts anyway. There are now over 15 million people aged 60 or over, and they make up nearly a quarter of the UK population. And I speak about this as a sort of detached thing. I'm not quite there yet, but a lot of my friends are now hitting this point in time. I can't believe it, and I still think we're talking about other people. Because I'm 23, I'm still 23. You will have an age that you stopped at. Yeah, well, I'm still 23. Of that 15 million people, we know that nearly 900,000 of them have a problem with their memory. It's a dementia problem. But that's not the only problem that happens with older people. It seems to be, of course, we've got this tsunami problem of dementia in our older population. It isn't the only thing that they suffer from. Along with that, of course, we get the number of old people is also increasing. 3 million people aged 80 or over, which is really quite remarkable. You younger people would take this as normal. It is new, it's not what's happened in our society before. And over half of those 3 million people are aged 90 or over. And it used to be the case where people would go, 91? Really? My goodness. Where now it's, oh yes, they're 91. Are they still driving? Yeah. In 21 years' time, in 2039, it's expected that there will be almost 22 million people aged 60 or over, more than half as many as there are today. So this population isn't going away, it's getting bigger. The baby boomers amongst us we'll have a big vote, we'll have a big strength, we'll have a big spend, we'll have big needs, we'll have big hopes and expectations. Something else to note, only 416,000 people live in care homes, that's residential or nursing care homes. It is only 4% of the population aged 65 years over, and of course amongst the older age group a higher proportion are living in that care. And it's almost a knee-jerk reaction when we talk about older people, heads go straight away, oh well, nursing homes, when in fact these days only a very small proportion of people are there. By far the biggest proportion of older people are either free living, either with or without support, or they might be receiving care in their home services, or they may be living with their relatives who are caring for them, or they could be living in supported housing. So that's a far greater number of the population that I still think we need to care about. There's obviously a lot of interest these days from a population, from a community activity point of view, in improving experiences in care homes from the oral health point of view, but I think we also need to be looking at all the rest as well. So what about the dental condition of adults these days? You can see here we've got trend data because we've done 10-year surveys for 40 years in England, and this sort of data is the envy of the world, I can assure you. And this graph talks about the percentage of people who are edentate. So just to help you out, because I'm really slow at looking at graphs, so help you out. So you can see on the vertical axis the percentage of people we're talking about. And the top line, the dark blue line, that was people of different age groups who were examined in the decennial survey in 1978. So teams of interviewers would go to homes, ask people to take part. Trained and calibrated dentists would go to people's homes and undertake a dental examination. Huge undertaking. And you can see that when they examined the 16 to 24-year-olds, hardly any of them were edentate in 1978. But when they looked at the older age groups, the 65-year-olds and over, they had nearly 80% of them were edentulous. You contrast that then with the aqua line towards the bottom, and you can see that people are becoming edentulous much later in life, and far fewer of them are edentulous. You can see that line is just over 21%. We know this data is now out of date, and we're very, very hopeful that someday soon funding will be found for another adult dental health survey. And I think we can predict where the curve would go for it'll be the 2020 decennial survey. It's going to be an even more improved picture. It's an amazing success story. If we look at them then, these same groups of adults, and you look at the percentage of them with 20 more natural teeth by age. So that 21 or more is sort of classed as a functional dentition. And you can see that this, again, we've got the 1978 line, and you've got 20% of our 55 years and older had got 21 or more teeth. And then we contrast that with the aqua line, where over 60% of that age group have got 21 or more natural teeth. Lots of teeth around. So that's great. That means we've got a much healthier dentition. But of course it means we've got more teeth to become carious, more surfaces available. We've got more teeth that can be periodontally involved. We've got more root surfaces that can become exposed. So there's an upside and a downside, but I know which I would rather have. If we look then, another piece of information from that survey, the average number of teeth by age for each of these groups. And you can see that what you would have expected is that the average number reduces over time. But still, amongst those who are 85 or over, they've got 14 natural teeth on average, which is really good news. It's fantastic. So just some other summary figures from that survey. And these give a clear evidence that caries, rather than being restricted just to children, which seems to have been the sort of myth that's been around for a long time, certainly affects adults. Just under 1/3 of the adults examined in this survey, and they were a representative population sample, had obvious tooth decay. So that's visually obvious caries that was interdentine. So that's, it's quite a chunk, isn't it? We've still got people walking around with decay, adults. A third of them, and they were not just little bits. So those who had got any decay had got 2.7 teeth affected. So it wasn't just the odd accidental bit of caries. Those, if you'd got any, had got nearly 3 teeth had got caries interdentine. And that the prevalence of this varied with age. So amongst our 25 to 34-year-old volunteers, well over a third had got caries in the crowns of their teeth, and it was less in the 65 to 74-year-olds, with only 22% affected. But still, 1 in 5, it's quite a high proportion. And then I've picked out this particular piece of information about root decay. So 7% of overall of the adults had active root decay. But this again varied by age, with 1% of the 16 to 24-year-olds affected, 11% of the 55 to 64-year-olds, and 20% of the 75 to 84-year-olds. So root caries is clearly a significant problem in the older age groups. This slide then just shows the proportion with primary or secondary caries, so brand new caries or caries associated next to or on the same surface of a tooth that's already restored. And you can see that 28% of the 85 and overs had got some sort of decay, primary or secondary. If we focus just on root caries and the risk of root caries, this was what was found. The percentage of people with any exposed roots, 73%. Remarkably high proportion without having that risk. And those who had got any, on average, they had 7.3 teeth exposed, got vulnerable roots exposed. And the percentage of all teeth with exposed surfaces, 29%. So we've said already, those with active decay on roots, 7%. We don't have to worry about the weighted and unweighted base. I've just taken these figures directly from the Adult Dental Health Survey, which is still available for you to find. It's archived, but you just Google it and you could find it. Just the last one here then about this national survey, and it talks about the risk of root caries by age. And you can see on this that amongst the 85 and overs, the number of teeth with exposed roots, they've got 11 of their teeth. So exposed root surfaces were widely prevalent. Just a little summary as well, that in this survey, they had a little classification of those volunteers who had excellent oral health, and they had a definition of what excellent meant. And they found that excellent oral health was highest amongst the young, those who were in professional and managerial occupational groups compared to other groups, those who were regular attenders, those who had made an attendance at the dentist most recently, those who were twice daily brushers or more frequently, and those who had never smoked. No surprises, but it still is a confirmation there of the clean living that can produce that excellent oral health. So now I'd like to tell you about another national survey that happened more recently. This happened in 2016-17, and it was coordinated by Public Health England, who now have the role of coordinating national surveys, except for the decennial surveys. And there was clear need because the customers for that information are local authorities, and local authorities are responsible for improving oral health in the population. And they were asking for more information about adults. They knew we'd got lots about children, we'd got information about 5-year-olds and 3-year-olds and 12-year-olds, and they wanted to know more about adults. But actually adults are really quite hard to pin down, quite hard to encounter, quite hard to do a survey. And we decided we wanted to focus on those adults who were most likely to become dependent soonest. We knew we got lots of information about adults who were already dependent. They were the ones living in residential and nursing care. We'd got information about perfectly all right adults, free living in their own homes from the Adult Dental Health Survey. But those who were just in between, we wanted to know about those. So it seemed to be obvious that what we needed to do was contact units where people lived in supported housing. So it used to be called sheltered housing, but there's sort of extra support. And the belief is that people move into this sheltered or supported housing, and there will be somebody there on site who could keep an eye on them. And that was the group we wanted to survey. The Elder Accommodation Council had a list of all of these sorts of older places where older people could live, and we worked with that list. We removed from it the sorts of housing which is where people want to go and just play bridge and golf. So those sorts of that sort of housing, the flashy adult housing, we removed from that, and it left behind anywhere that was classed as extra support. We trained and calibrated teams from all across the country, and they made contact with the providers of these units, these developments, and then where there was permission, they went and contacted the managers, and where there were managers, they were able to contact the residents. That was not without multiple difficulties. However, the teams did finally undertake this survey, and they did a questionnaire with the older people in the supported housing, and they did a simple clinical examination. So this just summarises it. PHE coordinated. We produced a national protocol to make sure that everyone was doing the same thing. It was standardised. We could make comparisons from East Anglia to West Shropshire. The fieldwork teams met with older people and gained their consent. They ran a questionnaire with them, and they did a clinical examination. Just a little note within the questionnaire, we also asked a simple question just to get a very blunt idea of memory recall. So at the very beginning of the survey, the volunteers were asked, they were just given 3 words and asked to remember them. So it was apple, pear, table, probably. If anyone's ever been with anyone for dementia monitoring, that's one of the ways that they just ask it. At the beginning of the interview, to monitor how it's going, they give them 3 words and ask them to remember at the end. And then at the end of the questionnaire, the volunteers were asked, do you remember we said those 3 words? Can you remember what they were? And some people said, oh yes, and gave the 3. Others struggled and gave 2 or 1. And some people said, I don't remember you saying any words to me. But that gave us a measure of short-term recall. And you'll see why in a moment. All the information across the country then was collated all together, cleaned and collated and analysed, and we published this report that you can see up here. And we called it the National Survey of Mildly Dependent Older People, and probably took a great length of time trying to choose the right title for it, so no one was offended. It described what we wanted, and it was understandable. We are currently evaluating the method. In fact, we did evaluate the method that was used because it was new. We didn't know how well it would go. There were problems, I have to admit, getting in touch with the providers of those residential areas. There were problems getting hold of managers, which sometimes they just did not exist. So there were some supported housing places where everyone went and had lunch provided for them, and there was a manager on site who would go and knock on doors and say, how are you today, and take their newspapers. And in other places there was virtually nobody there, and the older people would say they couldn't even get a light bulb changed. That in itself, I think, is a big worry, because the belief is, of course, that these people are in sheltered housing and they therefore have some support, but in fact they have none. Sometimes the managers were very helpful and cooperative and all went well, and sometimes not so. Sometimes they felt that they should protect their older residents against people coming and wanting to undertake surveys of them, which is difficult to argue with. And it seems to sort of a crowd activity. If 1 or 2 people in the units would say, oh yes, I'll take part in that, and I'll get Gladys to do it, and I'll get Joan to do it, or if they went along to a coffee morning and chatted them all up, they'd either all take part or they'd go, oh, I don't think so. So it was not without its difficulties. Anyway, we had really good participation levels. Our customers, we had, and the commissioners of this, we had 132 upper tiers took part. So 9 out of 10 of the upper tier local authorities took part, and that produced information for 82% of lower tiers. And we were able to undertake questionnaires with nearly 11,000 residents of supported housing, and not all of them had a clinical examination, but still a high proportion of them took part. These are some of the findings then. 9% of the volunteers reported current pain in the mouth. Not an insignificant number of people with pain. I was talking with someone in the audience earlier about how you can be floored, you can be doing okay until a minor thing goes wrong with your body. For example, a foot problem. Suddenly people, they're almost disabled by it. Or if you've got pain and you can't go out and about, or you're made more depressed by it, or you're embarrassed by it, or you can't eat with others because of it, it has that significant impact, doesn't it? We found that 7% of the volunteers had a puffer condition. And I've put the definition of that, in case you think it's polyunsaturated fatty acids. It's not. A PUP condition is about if they have an open pulp and or traumatic ulceration and or an abscess or a sinus or fistula. And it really describes the far end of the corollary of untreated caries or inadequately treated caries. And in fact, it was developed generally for sort of third world countries, but it works very well in other developed countries. You can see that 7% of the people taking part were walking around effectively with pus or with soreness. A high proportion of the participants reported having seen a dentist in the previous 24 months. We accept its reported figures, but it's still a high reporting level. 9% reported having discomfort when eating, often or very often. You think how important eating is when if you're bored and quiet and at home, then the treat of the day is to have a nice meal, and if you can't enjoy it, then that's taken away. 27% of this population were edentulous, and only 1% had nothing to replace their dentition. They were edentulous and were happy without having dentures. And 42% had 21 or more of their own teeth. We found that poor oral health was found amongst participants who were older and who reported an increased length of time since they'd last visited, and those who said that they had difficulties leaving the house or could not get to a practice for a variety of reasons. And amongst this population, there were some who were still working. There were those who couldn't be examined because they'd gone out to have their hair done or they'd gone to the bingo that day. There were those who were housebound within that environment, so a whole range of people there. And of course, this one also comes in together. Those who had received services in their home environment, say the hairdresser came to them or the doctor always came to them or the chiropodist came to them, they would have been in the same group more or less of those who were restricted to attend a dental practice. We also found that those with reduced cognitive recall, those who could remember few of the words or none of the words, and those with a lower level of education tended to have worse oral health. Interestingly, higher impacts of oral health problems were reported by the younger residents. And this comes up again a bit later, which is an unexpected finding. I'm sorry if you can't see at the back. Your long distance glasses will need to go on. But you can see from this table here that we were able to compare across the regions. And in the northeast, we had the highest proportion of adults with no teeth. And the column on the right looks at the variation of those who are edentulous with no replacements. And you can see that varies a little bit, but not a great deal. Central SHA and South East Coast didn't take part, so I'm not quite sure why we've got a figure on the right. But you can see also by age, edentulousness increasing by age, but the replacement frequency is about the same. So here's this beginning to look at impact figures as well. If we look at the younger group, they were more likely to report. If we look at the blue column, 16% reported that they had to interrupt meals or avoid eating with others because of problems with their teeth or dentures. And that reduces to 13% in the slightly older group, and the very old even fewer. Similar figures, but not a great match, with the maroon bars, which is what was recorded at the 2009 survey of all adults. We think that the impacts, which appear a couple of other places as well, might be something to do with different policies for admission to supported housing, different social acceptability for people deciding to go in. They usually would go in because they have a social reason or a medical reason. There's some level of dependency. And possibly there's a change between those who've been there a long, long time and those who are newcomers to that situation. And we also think that the greater availability of care in your home services will have meant that people who could live alone but with a bit of care will not go into this into these categories anymore. They might have done at one time, but now they don't need to. So there's a shift in what sort of population are using this housing now. We found this interesting association, and it was found with a few measures as well of oral health. You can see on the left-hand side that those people who could remember 3 of the words that we said at the beginning had got a higher average number of teeth. Those who couldn't remember any of the words, only 11% of them, they had on average 11 standing teeth. I don't for a moment say that it's cause and effect. I'm not sure how strong the association is. I'm simply saying this is an observation that we found, so we will report it. If we just look at our puffer conditions, and has a question, hang on. Can you hold your question till the end and I can put the headset on? Is it all right? You know what the puffer conditions are, and you can see here that they were higher in the 65 to 74 age group than they were in the older ones, but they were of comparative level to the Adult Dental Health Survey. We asked the examiners with their epidemiology heads on, and they didn't know these people, they didn't have radiographs, they didn't have fully supine chairs, and all the proper full examination kit. They had standardised epidemiology field examining kits, and we asked them to give an idea of what sort of treatment they felt each of the volunteers needed. And you can see you can see on this table what sort of things that they felt were required. And we gave them very broad categories to choose. And the reason for doing this, I thought it'd be interesting for you to see this, the spread of it, and it was there really to help with commissioners who are buying services for older people. They also would have to judge how urgently this treatment was needed. And you can see that the examiners thought there was an urgent need for treatment in a very small proportion of cases. And the urgency was found to be higher amongst those who had more difficulty getting out to a practice, those who hadn't been for quite a while. So urgency was not a major thing, except if you were one of the ones who really needed care. I'll whiz by this bit. Here. We also asked the examiners to assess what would be the best setting, or perhaps the only setting where these volunteers could be seen and treated. And you can see that the majority, virtually 60%, could attend a dental practice with or without transport. So they were reasonably able to go and attend a high street general dental practice. That was fine. There was 5% who could only be seen within their own home. So domiciliary care, yes, was indicated, but that sort of tells you about the order of magnitude, about how many people in any patch needed their care provided in a domiciliary setting. The difficulty, the change that's happened, I suppose, over the years, at one time domiciliary care meant that you rocked up to somebody's house and you made full dentures for them, or you relined their dentures, or you repaired them. But you've seen that very few of these people are actually edentulous, and that immediately makes the dentistry more complicated, and immediately means that you really can't be doing many things in a domiciliary setting. And we need to be thinking of a different model of providing care for people who need that more complicated treatment. You can see that a big proportion of these people could only attend a dental surgery if they'd got extra transport, and they could only be seen either in a downstairs surgery or where there was a lift. And that's a big factor to be considering. So lots of steps up to the surgery underground floor doesn't count. It's got to be level access that we're talking about. And only a tiny proportion would need to attend a hospital department. And that would have been probably multiple comorbidities going on. So that gives us that sort of overview. So I now want to sort of talk about how best we can serve our older patients. And I think we do need to remind ourselves and the planners that the older people as a group is very, very far from being homogenous. So we've got some pictures here of people who might well be regarded as old, but they're so very different. If you think about Mick Jagger, well, he's old, isn't he? But he's still up on the stage. He's still jumping about like a spring chicken. Cliff's back. Yeah, great. And of course, there's my Uncle Jeff as well. So my Uncle Jeff, okay, so he's 86 and he's just set off to drive to the south of France to give the Alfa Romeo a bit of a run. How fabulous is that? That's the sort of old age we would want, isn't it? So we've got a whole range of those. And then we also know people who we've had friends, and from the age of 14 or 15, they had old heads, didn't they? They'd already sort of started slowing down at that stage. We've got a whole range of people, and each has to be respected as an individual, don't they? I think I'm doing some reading about older people and how many of them, along with the loneliness we hear about and the isolation, they also feel that they're invisible. And because they don't contribute to society, they feel almost guilty. And they sort of pass by with no one noticing them. And then you think, well, surely when they go to good general dental practices, they must be treated as individuals. They must be treated with respect. Sometimes they've been going to that practice for as longer than the practitioner has been there. And it's a chance for them to be seen as individuals and given a positive thought and care, physical contact, and someone who gives them a second thought. So and this population live very differently. They might be very frail, they might be strong, they might live alone, and they certainly aren't going to do anything else, thank you very much. They may have some memory loss, they may have a great deal. They might have high disease levels, they might have low disease levels. They might have low levels of demand, they might have very high levels of demand. And all of those need to be taken into account, don't they? So really, I think no matter what is your main principle of care for an individual older person, whether you're just looking to control symptoms or just do routine maintenance or reduce risk factors or do full mouth reconstruction or damage limitation or providing new prostheses or repairing old ones, whether you're doing minor surgery or you're accepting that stabilisation is all that's likely to happen. If you want to do minimal intervention, I think really in all of those sorts of cases, then proactive prevention is an essential element of your treatment planning. If you can reduce or stop deterioration, then that makes your life easier. It makes the outcomes more positive and more reliable and makes things better for that patient. So hopefully you'll all be aware of how, and for the past 11 years, prevention in practice has been guided by delivering better oral health. I won't embarrass you by asking you if there's anyone here who's never heard of it. But if you've never heard of it, please Google Delivering Better Oral Health, a document that summarises the evidence base for prevention for clinical teams, and in very simple tables it describes what advice should be given under various circumstances and what preventive action the clinical team should do according to very strong evidence base. And I've picked out from it the relevant summary table here. So the tables are divided into prevention of caries by different age groups and prevention of perio in different age groups, and another couple of tables. You can see here that on the column on the left, it gives you the sort of age group. So we've got all adults should be receiving this advice about brushing twice daily, using a fluoridated toothpaste, brushing last thing at night and on one other occasion, using a toothpaste that contains at least 1,350 parts per million fluoride, spitting out after rinsing to retain those benefits, and reducing the amount and frequency of sugar intake. So all of that advice should be given, plus for those who are giving extra concern. So all of those people who are walking around with a puffer condition, then you know they certainly are going to give concern. Those who've got active caries, a third of the population, they would be giving concern. Those with exposed roots, they would be giving concern. They've got like new areas for decay. So you might well consider them using a fluoridated mouth rinse. There's little point from a caries control point of view using a fluoride rinse, a rinse without fluoride in it, and they can positively cause a problem if they rinse away straight after brushing with fluoridated toothpaste. So on the right, the professional intervention would be to apply fluoride varnish of a sufficient strength to be able to bring about caries control, and to apply at least twice yearly. And for those with active coronal or root caries, consider a fluoride rinse and or a higher fluoride toothpaste, either the 2,800, but why not with adults? Would you not go for 5,000 parts per million? Because clearly the effectiveness of fluoride toothpaste or any fluoride is concentration dependent. So that summarises the evidence. Let's just look at these one by one. So we've got our adult patients who are giving concern, and we've got our Durafat fluoride toothpaste. This is the only one which is actually licensed for caries control in this country. And you need to be bearing in mind as a prescriber what your responsibilities are. If you're thinking of using a different fluoride varnish, then you need to know that there's evidence of efficacy, that it would be of benefit to the patient, it would be better than something that is licensed. And there's other guidance about why, under what circumstances people should be prescribing off-license. There are lots of RCTs that give support for the use of fluoride varnish, and some Cochrane systematic reviews. The most recent was in 2013, which put together all the reasonable, good RCTs from all around the world and put together in a meta-analysis the levels of benefit that can come from it. And they were able to show that you can get a 43% reduction in caries activity in the permanent dentition with twice yearly use of Durafat fluoride varnish. It can help with those where you've created lesions that are turned into self-cleansing lesions. It can be an adjunct to high viscosity glass ionomer cement, which now we know bond to dentine. It makes a whole difference to how you can manage those difficult spreading lesions, particularly those lesions that are going subgingival, that are just a nightmare to chase, aren't they? You chase them and you think, where's this going, and I won't have an edge. Well, perhaps with your glass ionomer, plus you've got fluoride varnish there, you've got the best sort of setup as to stop it spreading further. So the other advice is also about high fluoride toothpaste. Again, those who've graduated in the past 10 years or so, you won't remember a time when this didn't exist. And when I was treating particularly special needs adults, I really wished I'd had that high fluoride toothpaste, because I could hardly keep up with the caries in some of them, and I felt I just wished I'd had that tool around. So it can be prescribed for patients to use, and people ask, well, should you go for 2,800 or 5,000? And if we're talking about the older adults, then why not go for the 5,000? So hopefully you've seen from my talk that you can see what's going to be coming soon to a practice near you, what will be a reality of this crowd, of this new population, and hopefully they will have high expectations and a positive outlook about retaining their teeth. The years of knowing that their grandparents were edentulous and that was okay actually will have gone, and we have a new expectation from that population. And hopefully I've made you reconsider, if you hadn't already, the best way to involve prevention and have it at the heart of your treatment plans for a wide variety of older patients. Thank you.